Hey everyone, thanks for joining today's webinar, Telehealth and Rural EMS, which is part of this year's Telehealth webinar series. I'm Nicole Clement, a program specialist here on the TASC team at the National Rural Health Resource Center. The learning objectives for today's webinar are that following this webinar, participants will be able to describe how the use of telehealth benefits rural ambulance services, discuss the financial considerations of telehealth for rural ambulance services when there isn't reimbursement for it, relate telehealth implementation tips for rural ambulance services, and recognize support available to rural ambulance services interested in utilizing telehealth. Patricia, will you launch the polling, please? While I introduce our speakers, if you would all just take a minute to answer these pre-presentation questions, that would be great. Our speakers today are Matt Zavadsky of MedStar Mobile Healthcare in Texas and Jill Bullock of the Arizona Flex program. Matt is the Chief Transformation Officer for MedStar Mobile Healthcare in Fort Worth, Texas. He has helped guide the implementation and financial sustainability of numerous innovative programs with healthcare partners that have transformed MedStar fully as a mobile integrated healthcare provider. Most recently, he has led the negotiations with multiple third-party payers to change the basic economic model for EMS to better align patient, provider, and payer focus on patient-centered care as opposed to simply payment for ambulance transport. Matt is also the immediate past president of the National Association of EMTs, or NAEMT, and chairs their EMS Economics Committee. He is the co-author of the book Mobile Integrated Healthcare: Approach to Implementation, published by Jones and Bartlett Publishing, and he has a master's degree in healthcare administration with a graduate certificate in healthcare data management. Jill has been with the Center for Rural Health in Arizona and working on the Arizona Flex program since 2011. She has over 25 years of experience working in government and nonprofit entities in healthcare marketing and outreach to the underserved. In 2014, Jill became the Flex Coordinator supporting Arizona's 16 critical access hospitals and their 38 affiliated rural health clinics. In 2015, she was appointed the Associate Director of the Center for Rural Health. And with that, I will turn it over to our speakers.
Thank you, Nicole, and thank you, Jill, for joining us. I just want to do a quick check. Is the screen showing with the slide deck?
It is, yep.
We're finally learning how to do virtual meetings. So.
It's only been 2 years.
Yeah, and hopefully not much longer, but it is relatively convenient. Okay, so let's see. I want to move this on my screen to get it sort of out of the way, I think, or maybe it'll just go away when I start moving through. And again, thanks. Jill has a lot of experience that she's going to share with the group on doing this in a rural community, rural state. And I'm blessed to have the fortune of doing this in a number of communities, and ours specifically. But as everybody knows, rural communities are often much different than urban communities like the one that I'm in. So as Nicole went over the objectives, it's really good. I want to just highlight a couple things. One is there's not always direct reimbursement for that care. And we're going to share with you some of the ways that rural EMS agencies can be reimbursed for this service, because there are multiple payment opportunities that they can take advantage of. And Jill specifically is going to highlight some of the things that she has done in Arizona to help facilitate telemedicine for their EMS agency. So happy to be part of this process. Just for definition purposes, you may hear it referred to in different ways or may see it in different terms on the screen, but telehealth and telemedicine, we're going to use interchangeably. CMS generally tends to like the use of the term telehealth as opposed to telemedicine, because often telehealth can also include things like behavioral health services and other support services that might not be perceived specifically as medical care, if you will. But again, it's all this sort of virtual connection from a remote location to another location where a healthcare provider may be providing those services. So we're a little bit dealing in two times, right? So prior to the public health emergency, prior to the PHE, there was not a whole lot of use of telemedicine or telehealth because there were some restrictions in reimbursement. And this is really a lot of this public policy, if you will, related to telemedicine is based on the payment policy for telemedicine services. So prior to the public health emergency, the patient generally had to be in a healthcare setting, preferably in a rural healthcare setting. It had to be audio and video combined. The platform that you used had to be HIPAA compliant, which meant that the information had to be encrypted at the source, encrypted at the destination, and most importantly, and most problematically, encrypted in transit, which is what made wireless component of telemedicine and telehealth a little bit expensive and somewhat clunky. However, thanks to some of the issues related to the public health emergency, Medicare and CMS specifically issued a plethora of waivers that were designed specifically to achieve a couple of goals. One, continue to deliver medical care to people who could not access physicians' offices because they were closed, specialty offices because they were closed, and to help preserve healthcare system capacity in general, specifically brick and mortar capacity for patients who really needed to be in a hospital, in a clinic, in an urgent care. So the more that care could be delivered without having patients in a brick and mortar setting, it was felt generally that that would help preserve not only the capacity, but also still deliver healthcare to patients as they needed it. However, here are some of the waivers that were initiated. So as of March 6th of 2020, Medicare pays for office visits that could be done virtual. And that was begun to be used rather extensively. As you see there in the CMS release, those were the prior limitations, but the waiver eliminated those restrictions and, most importantly, opened up the ability for patients' residents to be a covered origin for telehealth. That alone was huge. So now a patient, a provider who was doing telemedicine for somebody in their residence could be reimbursed by Medicare for those services. They also issued a waiver regarding the HIPAA requirement. So what this meant was that the Office of Civil Rights was given great enforcement flexibility, which basically meant they don't have to enforce the HIPAA requirement. So FaceTime, Skype, non-encrypted mechanisms could be used for telemedicine. And in some cases, the telemedicine could be done by audio only. So even just a phone call with a provider would be eligible for reimbursement under this waiver. There's a summary of all of the waivers that were issued regarding telemedicine specifically, published on CMS's information page, and we put many of these links directly into the presentation. So when Nicole sends this presentation to y'all, you'll be able to just click on those links, go right to those source documents, and then there are other links that can help you find that additional information that you may need. The other thing that was done is there was another waiver that, and these waivers are still in effect, we'll talk about that in a second, that expanded the type of healthcare professionals that can do telehealth. So no longer was it just physicians, but it could be behavioral health specialists, and in some cases, other practitioners, shall we say, that could help patients more than just clinically or medically. So you'll see there physical therapy, occupational therapy. So there are a number of other healthcare professionals that are now allowed to also do telemedicine or telehealth to bring those services to patients. And this really does benefit the rural communities, because now people who need speech therapy or other types of therapeutics can do so in a remote setting. And what increased the ability or the availability of telehealth providers to do these services is because of the change in payment policy. We often say that Medicare, excuse me, does not tell medical professionals how to practice. They don't have regulatory authority over how practices are conducted. However, they control payment policy, and the change in payment policy changes practice because now they can be reimbursed in ways that they hadn't been reimbursed before. And again, here was the waiver that now also says that you can do just audio telehealth, not just video or video and audio, but just audio itself can be a reimbursable delivery model under that particular waiver. Now, for specifically as it relates to EMS agencies across the country and in rural settings, they also expanded what supervision meant in some delivery of telemedicine services in specific. So you'll note here in this particular language in the waiver that all sorts of agencies could be a qualified delivery model under a physician supervision, and they extended that supervision requirement to a remote setting. So what that set up for us was that entities that furnish ambulance service could be reimbursed for delivering those services by the practitioner. So here's the practical application there. Today, a physician could contract with an EMS agency or an ambulance provider specifically to facilitate a telemedicine visit. So if you're in a rural community and your local ambulance provider contracts with a physician group in a metropolitan center or a healthcare entity further away, and they say, hey, will you go to Scott's house and bring your device or bring my device or whatever, or Skype or anything that is covered under the waiver to facilitate a telemedicine visit. And we'll talk more about that with the connectivity in a minute. And I want to do a telemedicine visit with that patient. They can pay you for that. And that's an eligible expense, practice expense under this waiver. So this, again, even though the ambulance agency cannot bill or be reimbursed by Medicare for that service, they are eligible to be paid by the telehealth provider. And there are some models that are doing that, and it works very, very effectively. Here's some of the outline of coding and the things that are pertinent to telehealth services and telemedicine services for the provider. So if you're working with your EMS agency and you're facilitating discussions with hospitals or physician groups, here's some of the rules and some of the fee schedules that have been put in place, not only for the pandemic, and there are codes specific to the operation during the pandemic, but there are just some sustainable codes that the practitioners will use to bill and be reimbursed for Medicare and most other providers. Now, the thing that I highlighted here for you at the bottom is notice that this 99281, 99282, and 283, those are emergency department visits. One of the interesting parts of the waivers that have been issued under the public health emergency is that emergency physicians can be reimbursed at the same rate as if the patient was in the emergency department, even though they're doing that visit through telemedicine. So for emergency medical services physicians and ER physicians, they're going to get paid the same if they do a virtual visit with that patient or they have that patient in the emergency department. That is huge for the emergency physician community for all sorts of reasons. But again, this was all done in a way to reduce ER visits, reduce hospitalization, preserve healthcare system capacity, but still be able to deliver healthcare to people who needed it in their homes, which may be an hour and a half, 2 hours, 3 hours away from that hospital. The ER physicians get reimbursed at the same level for the telehealth visit as if that patient were in the emergency department. We'll talk more about that as we talk about the sustainable. Well, we'll talk about it now. I forgot that I put this in here. No, I didn't. Nicole, don't worry. I remember, I know everything that's in this presentation. There's been a lot of discussion about sustainability and the continuation of these waivers beyond the public health emergency. Almost all of the Medicare waivers, the CMS waivers that have been issued to change payment policy, they all contain a phrase that the waiver will expire at the end of the calendar year in which the public health emergency is declared over. So in practical terms, what that means is if HHS says today that the public health emergency is over, the waivers that have been issued all the way back to March of 2020 will continue to be in full effect until December 31st, 2022. Now, and that because that gives everybody a chance to unwind and put other systems back in place. The public health emergency, as many of you know, has just been renewed for another 90 days. They're typically 90-day increments. The HHS has also told the healthcare industry that they will give us 90 days notice that they're going to discontinue the public health emergency. So if you think about that in calendar terms, July 1st, they just renewed it for another 90 days. That brings us to July, August, September. So they have not notified us that in September, they're going to allow it to expire. So because they haven't told us, this means realistically, they're going to renew it again on October 1st. That brings us to essentially December 31st of 2022. It is likely, especially with some other emergency things that are going on with monkeypox, as well as the most recent wave that we're having in the most recent COVID variant, that the public health emergency will continue into calendar year 2023. So even if they declare on January 1st of 2023 that the public health emergency is over, these waivers will stay in effect until December 31st, 2023. So we've got a lot of time for these waivers to stay into effect. However, the CMS Office of the Inspector General and others have expressed a slight concern that the expansion of reimbursement for telemedicine has led to some fraud and abuse in telemedicine. So Congress recently required the Office of the Inspector General to do an analysis on whether or not telemedicine has been fraught with fraud and abuse and make a report to MedPAC, the Medicare Payment Advisory Commission, to determine should the telemedicine waivers stay in place, should they become permanent, how much has they created this fraud and abuse issue. And if there is a lot of fraud and abuse, it's possible that MedPAC recommends that the telemedicine waivers are allowed to expire because they're not creating a lot of clinical benefit, they're costing a lot of money. That could be possible, but they're part of that congressional action gave time for that analysis to occur. So even if for some reason these telemedicine waivers could expire at the end of this calendar year, Congress passed language that allows the waivers to stay in place for 150 days after the end of the public health emergency to give the OIG time to evaluate whether or not the fraud and abuse should be a concern by keeping these telemedicine waivers permanent. And we're happy to answer any questions about that when we go to the Q&A session at the end. Okay, so how does all this help the rural EMS provider and more importantly, the rural communities? Well, first, you can reduce ambulance out of service time from 911 calls. If you're in a remote rural frontier area, you know that a 911 call could have a 2 to 3 hour or longer out of service time for the one ambulance or maybe one of the two ambulances that community has available to them. However, by using telemedicine to do on-scene enhanced assessment of patients, the physician or the nurse practitioner, whoever is doing the telemedicine, could help the EMS agency and the patient determine, hey, you don't need to go all the way to the hospital. You can receive a good treatment in place. You can go to an alternate destination within the community that keeps the ambulance more local and shortens their task time to keep those resources more available. So that certainly helps. It could also help reduce ambulance responses. So if your rural agencies are using a mobile integrated health program, a community paramedic program, or they're just going to facilitate some telemedicine services, they could prevent 911 calls, which then again prevents the ambulance being out of service for a long period of time and keeps those resources in the community. To give an example of that in specific, so at MedStar, we've been doing a telemedicine program as part of our ET3 program since April 1st of 2021. And you'll see some of the data here. The first thing I want to point out is that we've offered telemedicine. All of our ET3 interventions start with a telemedicine intervention, if you will. And we've offered that intervention to about 800 patients since April of 2021 and growing every day because the crews are getting more comfortable with doing it. And of those 789 telehealth interventions, 727 or 93% of the patients are treated in place. They're not transported. So imagine that in your rural community where you have these patients that call 911, they have a clinically eligible assessment to be in a potential alternate disposition. Telehealth is engaged. The vast majority of those subset of patients don't go anywhere. We don't do a lot of transport to alternate destinations, even though we've got an urgent care center in every street corner in our community. They're really not necessary because we have other resources in place for those patients. But imagine that those patients don't have to be transported out of the rural or the frontier area. That does preserve a lot of EMS resources, but it also makes it a much more patient-centric disposition from that 911 call. Another benefit is to enhance community health. As we talked about, the telehealth provider could contract with the local ambulance provider to facilitate better health in the community. So the patient has a medical complaint, and instead of them traveling all the way to the hospital or to a medical office building or to that out of area medical practice, they can just bring that to the patient. And this what we call EMS on demand, meaning that we're going to take the care to the patient instead of bringing the patient to care, will really help enhance the community's overall health. And then revenue. So revenue, we know, is a huge issue right now for all the reasons that you guys know probably painfully too well. But right now we can get paid for non-transports. We'll talk more about that in a second, but in case I forget, one of the waivers that Medicare issued was the ability for EMS to get reimbursed for treatment in place if it's part of a local medical protocol implemented by their medical director. So if your agency's medical director said, hey, low acuity patients, we're not going to take to the hospital during the public health emergency because we're trying to preserve healthcare resources, blah, 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 then all those patients that you don't transport using that protocol can be billed to and be reimbursed by Medicare. So that really helps quite a bit. And that waiver is still in place. There's also an alternate destination waiver. So a lot of those models are in place. Second is, again, the physician practice that's doing telemedicine can pay the provider for being the facilitator of that. And that helps quite a bit. And by doing this, the agencies demonstrate greater value to the community, and they may get more donations. They may get more other support from the local community that enhances their revenue because the people in the community recognize that the EMS agency is doing a lot to kind of keep people in place. And this was just, again, to highlight the fact that ambulances can be reimbursed by those agencies. Now, to give an example of that, in our community, not only are we getting paid by ET3, but we're seeing and we're experiencing commercial payers want to pay for non-transport, because now that Medicare is doing it, it's safe for the third-party commercial insurers to do it. So this is an example. We just entered into a contract with our second largest commercial payer, and they are paying us for treatment in place. And here's an example. It's de-identified, so I can't get in trouble for violating our non-disclosure agreement. But notice a couple things here. Under this agreement, they pay us $1,127 to transport an ALS emergency patient to the emergency department. But notice that if we don't transport the patient to the emergency department using that HCPCS code of AO998, they're paying us almost exactly the same to not transport someone as they would to transport someone. So this incentivizes us and other agencies to do the right thing for the patient, figure out what's the best resource for them. If we don't transport them, we're going to get paid the same regardless. Historically, EMS takes a financial hit for not transporting someone to the hospital because we only typically get paid for transport. But now even the commercial payers are paying this, and Anthem's doing it, and Cigna's doing it, and United is starting to do it, and WellMed. So they're recognizing the value of EMS not transporting patients and getting reimbursed the same whether they transport or not. We also had great success convincing Medicaid in our state to pay the same thing. And many states are, under their Medicaid guidelines, implementing the same thing. So this last legislative session, we got a bill passed that basically says, hey, EMS agencies are going to be paid for non-transport or transport to alternate destinations, very similar to the ET3 model. However, we made some suggestions to enhance that process, specifically making it eligible for all ambulance providers, not just those that are approved for ET3. When the rule came out, we were thrilled. We had worked very closely with the Medicaid office here in Texas, and we talked a lot about some of the challenges in rural Texas and frontier Texas with things like telemedicine and alternate destinations. And so very limited number of agencies actually being ET3 participating agencies. So when the rule came out, it basically said this was the published rule for the 90-day comment period. And it changed the eligibility guidelines, and it said that an ambulance provider may transport a patient to an alternate destination. The ambulance provider may provide treatment in place. And notice that this is protocol driven. It doesn't require telehealth. So we were thrilled with this rule. And in fact, our comment to HHSC on the public comment period was, thank you, we're good. No comment. We fully agree with all of this. And it's been one of the few times that HHSC has made any type of change in payment policy for ambulance providers that literally got all positive comments, and we were good to go. So that actually goes into place September 1st. So in just a month, a little over a month, Medicaid and all managed Medicaid will be paying for treatment in place. And that's an important distinction. You know, under the ET3 model, that payment policy for telemedicine, for example, is only for Medicare fee-for-service. Managed Medicare doesn't have to pay it because it's a model. It's not a change in coverage. The Medicaid rule in Texas and in many other states is a coverage change. So both fee-for-service and managed Medicaid must pay the same. So for us, managed Medicaid is about an 87% market penetration. Very few patients are on traditional fee-for-service, if you will, Medicaid. But to be honest, the managed Medicaid payers were all very supportive of this legislative change because it helps them financially as well. So there's a lot of support. Now, we know that there are also technology issues in rural areas. And thankfully, FirstNet, which is built with AT&T, we always have to say that, as you all know, has been funded heavily by the federal government to build a broadband cellular access really across the country. 99-point-something% of the country is their contracted requirement, and they've made great progress. This is some data that we just got from FirstNet this week. So you can see that they are ahead of plan in bringing broadband, say that 3 times fast, coverage to the country, most especially the rural areas, and they've done a really good job with this. I'm going to talk a little bit more about the technology and then turn the floor over, or the screen over, to Jill to talk about her experiences in Arizona. But just know that in addition to having the availability of this across the country, and most importantly in the rural areas, we've also seen the development of what they call high power user equipment, which basically takes a handheld cell phone technology and builds a much more powerful transmitter into an ambulance or an emergency vehicle that amplifies a signal through Wi-Fi, so you can get much greater distances covered to be able to hit a cell tower in a frontier area. Because instead of a 2 or 3 watt transmission on a handheld device, using some of this high power equipment, you can literally get 100 or hundreds of miles of coverage from that high power user equipment to give the EMS agency, the police department, the sheriff's office, the fire department, much more connectivity using that broadband. So Jill, you've done a lot of work with your agencies in Arizona. Do you want to take a few minutes and talk about what your experience has been?
Yeah. So hi, everybody. I did give a presentation at the reverse site visit on our demonstration project that we did. So many of you may have heard me already speak to that, but today I was asked to speak on how we used FirstNet. And so the Arizona Flex program was one of the 8 programs, or one of the 8 states that received the EMS supplemental funding in 2019. And it was a 3-year funding. And in Arizona, of course, we have to have acronyms for everything. We called it the Arizona Rural EMS Advanced Telemedicine Demonstration Initiative, or AZ-READY. Of course, we need acronyms. So this was to develop a telemedical infrastructure that places rural EMS agencies at the cutting edge of medical care. The purpose was to connect our rural EMS providers with board certified EMS or emergency medicine physicians in real time using two-way video communication. So the purpose of this grant, or how we got the grant, was to demonstrate this model and keep it a sustainable model of the rural EMS care by providing this medical direction at the time of patient care to assist basic life support and advanced life support providers, and in the evaluation and triage of the patients in rural communities. So basically, the project was as the right patient at the right destination via the right transport modality. And this project really focused on chest pain. And so using the AZ Ready telemedicine system when it was safe to transport patients with chest pain, this would ultimately leave an advanced life support unit service in your area to be able to respond to the next call. So that's what Matt had said. I mean, the transport and taking away an ambulance for long periods of times leaves your community vulnerable to having no ambulance service at all. So similarly, when it was safe to transport patients via ground or rather than air, so either way, it saves the patient and providers money. So we started talking to FirstNet probably 5 minutes after we were awarded this funding opportunity, because FirstNet is a dedicated network for first responders. And this project was being conducted in 2 very rural areas. One in the Rio Rico, which area fire, EMS and fire, which is not very far from the Mexico border. And the other project was Sonoyta Elgin area, which is very remote in wine country and close to the border as well, and had very, very spotty, if any, internet. So again, we met with FirstNet right away, and FirstNet was on board. And if there was no broadband FirstNet cell towers in those areas, they're committed to putting those cell towers in those areas. They also supplied the iPhones for essentially free. I think they were $1 each because there was something there that they had to charge for. And then a very low monthly fee, which our grant was paying for. And Sonoyta Elgin Fire Department used only the iPhones. They had prior to this flip phones. So this was a real move up in their technology. And the Rio Rico Fire Department only used iPads, and they used the FirstNet what do you call it? The FirstNet system, dedicated network to connect the iPads and their cell phones so that they could connect their telemedicine. It's called the one that they used was eBridge platform. So they needed the FirstNet platform to connect the other telemedicine platforms. And so that's how this system, or that's how Arizona used the telemedicine in connecting our rural areas. I have a lot more slides on this. If you were at all interested, I could send them to you. I wasn't supposed to really talk about how that is, but if you're going to do a project like this, bring FirstNet in at the beginning. And then if you aren't already connected to your telemedicine program, your their regionals, we actually have the Arizona Telemedicine Program, which is the Southwest Telehealth Resource Center as well. They're in our backyard. They're part of the University of Arizona. So we have a great relationship with them. So if you don't have a great relationship with your telehealth resource center, I would start there. And they actually helped test all of the systems that were used to decide which platform that was to be used for this demonstration project. So for any of you thinking about, that's where I would start first. That's all I have, Matt.
Yep, and I do know where the mute button is, so I apologize for that. Thanks, Jill, and we'll have some good time for Q&A at the end. I promise to get through this relatively quickly so that we don't bore people to death. So program development, we've talked a little bit about this in the past, but just as a reminder, a couple of things to keep in mind. There is a lot of community support, and make sure that you have community support for doing these programs. Medical director, number one, most important, the medical director for the EMS agency has to be fully on board, and then certainly any regional or state authorities. The field staff, really important, leadership of the agency, leadership of the local community, the medical groups, hospitals, and generally what we have seen in talking to some of our rural partners, there's almost always tremendous support for things that are going to do the things that we talked about already for the EMS agency and for the community. Make sure you check your cell coverage. As Jill mentioned, a propagation study basically is just having FirstNet come out or some cell company check the area and see if they need to move things around, if they need to, whatever. What are some good sites? What are some equipment they recommend? Use FirstNet if you can. They're being paid by the government to do this, so they are a great resource, and we have found them to be extremely responsive, not only as an individual agency, but also through NAEMT and others. They are great partners and do a lot of things to really help the EMS agency. Select the right telehealth partner. I will share with you in a minute that there are a lot of them, especially since these waivers have been issued. Make sure that you're involving the EMS agency's field staff, the leadership, the billing agency in the selection of what telehealth partner you're going to use. All of them have different platforms. They have different processes. Find the one that works best for you, even the types of providers that they use for their telehealth program. Make sure there's some type of economic model where the EMS agency is benefiting economically from doing this, because otherwise there's really no good long-term sustainability for the program. Make sure that working with the local authorities and the local healthcare folks that you have good eligibility guidelines for which patients would qualify for a telehealth intervention. If you're going to do treatment in place, what's the follow-up on those patients? Sometimes it's the EMS agency doing a follow-up in 12, 24, 36 hours. Make sure the patient's doing okay so you don't have any bad outcomes, because that's bad, obviously. If you're going to do an alternate destination program, make sure that you vetted that pretty well. Even in the Texas legislation, as well as some of the other state Medicaid legislations that authorize alternate destinations, the alternate destination provider has to be a committed partner. They're willing to take those patients given certain clinical eligibility guidelines. So make sure if you're helping your local EMS agencies that you help them with some of those processes as well. And again, make sure that they're maximizing the treatment in place. We, in addition to the Medicare treatment in place program, we bill for treatment in place in general. And we find that there's a fair number of payers that are paying for that. And in some cases, we're billing the patient, and the patient pays because it's a billable service, and we bill them the correct HCPCS code, and just figure out if there is that economic model for treatment in place or transport to an alternate destination. This is an example of our MedStar eligibility for telemedicine or an alternate disposition. Notice that it is pretty straightforward. It includes patients who might be AMA, which is another whole discussion. There is a current eligibility guideline related to the patient's payer source. That is an important consideration. We now currently offer an AT3 or a telehealth intervention for patients who are on Medicare. And we thought that there would be a lot of pushback from the field EMTs and paramedics, because they're going to offer something to a certain payer class that they're not offering to other payer classes. That was not a hurdle. They bought into that pretty clearly and pretty quickly, because they recognize that, hey, if we bring this person if we do a treatment in place on someone that we're not going to get paid to do treatment in place, why would we do that? Let's just take them to the hospital, collect our, $2,000 payment and be happy with it. But notice that clinically, basically it's a low acuity medical complaint. Vital signs are stable. And it's and again, it's a low acuity medical condition. There are some exclusion criteria that you see listed there because those are sort of high risk patients. Note that there is an ambulance not on scene exclusion. The reason that we do that is every one of our providers will not pay for a telehealth visit and an ambulance non-transport if there is not an ambulance on scene. So our standby units, our special response units, our bicycle emergency response teams, they can't do telemedicine. There has to be an ambulance on scene because we're not reimbursed unless there's an ambulance on scene. So that's part of the eligibility. How we do it typically is we get a standard EMS response. If the patient meets clinical and payer eligibility, the field crew basically just asks the patient a question. Hey, you are a Medicare patient and you're a very special category for us. And we would like to offer you something special that we only offer to patients like you. And that is blah, 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 telemedicine, treatment in place. We get you some follow-up care and the patient then consents to the telemedicine visit. That is an important component because you cannot bill for something the patient didn't consent for. So getting that loose consent, you don't have to, we say here, we don't have to read this word for word, but generally the patient has to consent to that intervention in order for it to be reimbursable to the various providers. If the patient does ask about a fee, we tell them, hey, you know, Medicare pays for this, they pay for the telemedicine visit, they pay for our visit. But if for some reason the payer denies payment, we have all sorts of things that we can do to help you pay your bill. If we transport you to the hospital, you're going to have the same issue, but you're also then going to have the hospital bill. So it becomes a pretty quick and easy conversation with the patient. One of the things from a program implementation, make sure that you're working with your EMS agencies to make sure they can document in their charting system, their patient care reporting system, that they did this. That's important for a whole host of reasons, quality assurance, program review, but also utilization change. So this is an example of some of the things that we did in our image trend patient care reporting system. These are relatively easy to change. We had to do some of this because we're an ET3 model participant, but we actually did some of this early because we were doing some pilot tests with other patients before we actually started the ET3 program. From a quality assurance standpoint, make sure that they are doing follow-ups on the patients that they do treatment in place or transport to an alternate destination as compared to patients who did. Just making sure that the protocols are correct, that there's not a classification of a type of patient that might need to be excluded because they end up having issues down the line if you don't take them to the emergency department. And just make sure that they're doing it well. Support for developing these programs. We were very intrigued by the fact that South Dakota, and Nicole, maybe you can tell us during the Q&A if there's somebody from South Dakota on the call, but South Dakota actually put out a statewide RFP for a EMS telehealth partner, funded by the state, setting up the program, setting up the protocols, providing the service. And this is an active RFP right now. They are interviewing telemedicine providers and others to actually facilitate this contract. Our current telehealth provider at MedStar was actually one of the bidders on this contract, and we were part of their development of their proposal to do that statewide system in South Dakota. So your state might be a good resource for supporting your system development. This is what's included is public, so I'm not telling tales out of school. This is South Dakota's RFP, and notice that they're really looking through their rural health office to enhance the ability for rural providers and others to be able to do telehealth. The National Association of EMTs and the National Rural Health Center has great resources that they make available. This is a screenshot of NAEMT's website. There were some webinars that we've done. We did a series of 3 webinars through NAEMT on telehealth program development and support and how to do it with some specific tools that can be part of that. So take advantage of that. Do not forget that the telehealth providers themselves have a aligned interest in doing telehealth programs with EMS agencies. So this is just a sample of the telehealth providers that are actively doing and developing even further EMS partnerships. Tele 911, I know very specifically, they are a phenomenal system that are doing a great job with many EMS agencies across the country. Integrative Emergency Services is the one that we're using at MedStar. MD Ally is another great one. United Concierge Medicine is a program out of upstate New York, and they have a great economic model for EMS agencies, and they bill and then reimburse the EMS agency for their time in facilitating the telehealth visit. They're doing it for both ET3 and non-ET3 model participants. DoxyMe, we learned about, they're doing a great job. By the way, I was always curious about where did they come up with DoxyMe as their moniker, but they explained it, say it 3 times, DoxyMe. DoxyMe, I get it. Okay, now it's telemedicine. DoxyMe, that's really wonderful and very cute. But so in summary, before we open up to Q&A, this is a great new opportunity for EMS and specifically rural agencies that are trying to avoid long transports and taking resources out of their community. As you could tell by program evolution and by now technology, that had been a limiting factor in the past. It's not so much anymore because of FirstNet, the things that Jill talked about, the high power and user equipment. Really high-powered user equipment opens up a whole new avenue for that connectivity. It does move EMS further into the healthcare space. We've now become an episodic care provider, bringing telehealth on a scheduled basis or an episodic basis to patients for additional revenue streams. Make sure that you understand the limitations of telehealth, patient consent being number 1, some of the technology being number 2, and the economic model, but try and work through it. But don't be afraid to try it. I mean, literally, we're all throwing spaghetti on the wall every day to see what sticks. And if we don't try something new, if you don't, they often say, and Nicole told me this, reminded me of this, I think at our last webinar, if you don't fail, it means you're not trying new things hard enough. So always push that envelope. With that, Jill, did you have any other closing comments? And if not, or add them, and we can turn it over to Nicole or someone to facilitate some Q&A.
No, I don't have any closing comments. Again, I did present our project last week. If you weren't on the call and you were interested, you can email me and I could send you a copy of it, or you can, if you were at the reverse site visit, you can grab or go listen to the recording. And just know that any first responder can use the FirstNet platform, and it's pretty low cost. So it might be a way for you to save costs on your cell phones and your cell bill. But that's all I have.
Thanks, Matt. Thank you, Jill. As Jill said, she presented on this just last week at the reverse site visit. We will try to include a link to that when we send out the recording next week. Anybody have any questions for Matt or Jill about what you heard today, or maybe something you didn't hear today that you're wondering about? Patricia, while we're doing this, why don't you go ahead and put up the post-education polling questions, please?
I think I have a question for Matt.
Go ahead.
I know that we were trying to do some ET3 and then it sort of stalled. How did you get it going in your state?
You mean with the Medicaid office in specific?
Or Medicare? Are you just funded under Medicaid now, because Medicare stalled, right?
No, Medicare, the ET3 program under Medicare is still active. The problem is that many agencies haven't done it. There were, just for statistics, there were I don't know, 500 some applicants about 260 applicants, 250 were approved, 184 actually went to the full signing of the participation agreement. Of the 180 some that signed the participation agreement, last we heard in the beginning of July, or at the end of June, only 41 have implemented. And of those, now here's the statistic that'll bake your noodle. Of the 41 who have implemented, only 12 have billed more than 10 ET3 interventions.
Oh,
That is scary. I think people realized that it's complicated to implement, that it takes real dedicated focus. And let's be honest, the implementation window opened just as the pandemic started. So people were distracted. There were other things going on in their local community. And to be realistic, many of the Medicare waivers that were issued as part of the public health emergency were ET3-like, meaning that people could get reimbursed for telehealth, get reimbursed for treatment in place, get reimbursed for transport to alternate destination, and they didn't have to be an ET3 participant. And I'll share with you that working with NEEMT and the International Association of Firefighters and the American Ambulance Association and the International Association of Fire Chiefs, legislatively, there is a ton of support in Congress to make those waivers for treatment in place, transport to alternate destination, and the telehealth waivers, making them permanent. So if those become permanent at the end of the calendar year, ET3 becomes the new coverage and we don't need ET3 anymore. So it's kind of interesting.
So it's kind of a wait and see right now. Because I was going to ask you to really like, how do we just really kind of build momentum on getting our providers and getting our EMS agencies on ET3, but I'm hearing wait and see.
Bill under the waiver for now, because again, and this was a conversation we had with our telehealth provider just a quarter ago. They said, hey, we're getting some of our ET3 claims rejected and, blah, blah, blah. And it was really a technical issue. It's not a coverage issue. I said, hey, if you get it rejected using the ET3 code, just bill it under the waiver. And they did, and they're getting paid under the waiver. It's like, let's just get pretty silly. Whatever.
Great. Anybody else have questions? Okay, I think that's it. Matt, as always, fantastic information. Thank you so much. Jill, thank you for your information about FirstNet. And that is all we have for today. So everybody have a good day. Thank you so much. Bye.